going to do that right now. If you do have your, I don't know if you have your computers on audio, but your phones, be sure and mute them so you cut the background noise. This session doesn't have any CEs offered in it, but we still would appreciate you completing the evaluation, which I'll send out after we complete today's session. And I think there'll be time for questions, won't there, Maureen?
Yes. Mm-hmm.
Could be. So put them in the chat feature, and she'll be sure and get to them. And just a quick little bit of information about Maureen. She's a registered dietitian and has been working in diabetes care since 2005. She enjoys working with clients and helping them to identify ways to live healthier, more fulfilling lives. She believes that nutrition is the foundation for building and maintaining a healthy lifestyle. Maureen has a PhD in mind-body medicine and, with an interest in wellness coaching. So all of that is to say that Maureen enjoys working with people with diabetes and with healthcare providers to improve the health of people in Wyoming. And with that, I'll turn the presentation over to Maureen. Thank you.
Thank you, Brenda. And welcome everyone after this 2-day after Christmas holiday webinar. I'm glad that you're all here. So today we're going to be talking about diabetes self-management, education, and support, and the National Diabetes Prevention Programs. And I'm going to try to address the what, why, and how of these programs. I do have, before I continue, I just wanted to also say that this program, my work is supported by the Wyoming Department of Health and specifically through the 1305 grant. And my supervisor at the state is Hannah Harold. So if you ever have any questions or concerns, please reach out to Hannah. There's her email and her phone number as well. And okay. So I have two objectives for today's presentation. One, we're going to really talk about increasing access, referrals, and reimbursement for AADE accredited, ADA recognized, or Stanford licensed DSME programs. And those three are similar. The one difference between those programs is the Stanford licensed program is not available for insurance reimbursement. So I just want to make that very clear as well. My other main objective is to increase referrals to, use of, and/or reimbursement for CDC recognized lifestyle change programs. So that's the National Diabetes Prevention Programs, and that aims to prevent developing type 2 diabetes. Okay, so oops. Let's see, I want to go back. So this is the kind of a snapshot of diabetes in America today. So right now there are nearly 30 million Americans that have diabetes. 1 in 3 Medicare dollars is spent caring for people with diabetes. And that accounts for a cost in America of about $322 billion. I want to talk a little bit about prediabetes. We have about 86 million Americans with prediabetes. And what else do I want to highlight on here? 1 in 5 healthcare dollars is spent caring for people with diabetes. And really, so when I go over these numbers, I always like to, get beyond the numbers and really talk about the fact that there's a person behind all of these numbers, and that person is, sometimes suffering with complications or trying to manage the disease and avoid complications in the future. So this gives us a really nice snapshot of numbers and statistics of diabetes in America, but then I also like to remember the human aspect of it as well. And so on the right side of this slide, I don't have a little pointer, but you can see that today diabetes will cause 200 Americans to undergo an amputation, which is quite traumatic, 136 to enter end-stage kidney disease treatment, and 1,795 people to develop severe retinopathy that can lead to vision loss and blindness. Now I'm going to take it a little bit, so we talked about the whole, America, but I'd like to talk about the estimated cost in Wyoming. The total inpatient costs for diabetes is over $232 million in Wyoming alone. And I thought this was a really interesting statistic too. So people with diabetes incur an average of $7,900 per year in medical costs. And that's, there again, that sometimes people with diabetes are it's just the costs are continue to keep rising. And so, one of our goals at the state is, especially this year, is really to work on prevention programs. And so to either prevent or delay people from developing complications. And hopefully, I think our bigger aim is to prevent people from developing diabetes at all. And that's something that we can do through lifestyle change programs. So this is the prevalence of diabetes in Wyoming. So I love to look at, I like statistics because I think, again, they tell a story about what's going on in our state. And you can see if we look at the numbers in Wyoming in general, it looks like we're doing fairly well. I think we're at about 8.6% prevalence in Wyoming. But when we break it down by certain counties, we can see those counties that are at higher and lower risks around the state. So you can see that Washakie County has a greater than 15% prevalence rate in Wyoming. And Hot Springs County is, what would that be? That would be 11 to 15%. Fremont County, 9.5 to 11%. Laramie County. So Fremont, Weston, Converse, Goshen, Laramie, and Uinta County are about that 9.5 to 11%. So, I would encourage you to look at this and look at your own community and see where you fall as well. So I'm going to talk about the Diabetes Self-Management Education and Support Program. And there are some recent changes. So what I'm going to go over today is going to reflect the current changes that have just been implemented that have just been developed. So this is kind of the latest and the most up-to-date information. So the DSME/S, it used to be called the Diabetes Self-Management Education and Support Program, is now the Diabetes Self-Management and Education and Support Program. And I'll talk about a little bit of the reasons why they've changed some of the names as we get later into the program. But I wanted to read you the definition of what a DSMES program is. It's the ongoing process of facilitating the knowledge, skills, and ability necessary for diabetes self-care, as well as the activities that assist the person with diabetes or prediabetes in implementing and sustaining the behaviors needed to manage his or her condition on an ongoing basis beyond or outside of formal self-management training. And there's a couple of key pieces that I wanted to point out in that this is really about, we're looking at sustainability. So working with clients or participants to develop healthy behaviors and habits that can assist them in implementing and sustaining behaviors that they really need to manage their diabetes. So this is the DSMES overview. So the overall objectives. So incorporates and this is really important too. So it incorporates the needs, goals, and life experiences of the person with diabetes and prediabetes. I personally really love this piece because of what they added in about, incorporates life experiences. So that really just points to how important the individualized care is becoming in our entire medical system. It is the information that we share with our clients is guided by evidence-based standards, and support includes behavioral, educational, psychosocial, and clinical. And so it's all of those pieces, not just the educational piece or the behavioral piece. It's all of those pieces together equals support. And so this support helps with decision-making, with self-care behaviors, with problem-solving, and collaboration with the healthcare team. again, I've been a clinician for a long time, and I know that this collaboration with the healthcare team is so important. We want our docs to know what our patients are working on, what they're dealing with, and so we want to really foster that, communication, and that communication with providers is going to really ultimately, and what we ultimately want is going to support the client, the participant. It also improves clinical outcomes, health status, and of course, quality of life. That's what we're really looking for. We're looking to improve people's quality of life. So these are the 2017 DSMES standards. And these standards aim to reflect the value of ongoing support and multiple services. DSMES is applicable to solo practices, large multi-center services, care coordination roles, population health, technology-enabled care models. It's for everything. And so with the new standards, they must be implemented by June 1st of 2018. And that's something that we are going to be working on from the state. If people need help implementing the standards or understanding what the new standards are all about, we can certainly help you with technical support for that as well. And I'll make sure that at the end you have my contact information and also Diane True's information as well. So here are some of the key changes. So again, I already talked about this, but it's now DSMES. So the support is included in the whole big program. So it's not just diabetes self-management education, it's education and support. And remember that support is behavioral, clinical, psychosocial. It's the big picture. So it's going to be called service instead of program. And instead of referring to a patient, we're going to be referring to them as participants. And we used to have program coordinators. They were people that, those were that was the person that was coordinating the program data. That new name is going to be a quality coordinator. And I think these are really, I feel like these are really good changes that really support the direction of where we're going with DSMES services as well, because it's recognizing the participant, recognizing that we care about quality, and of course, support. Support really for sustainability for the client, for the participants. So we have 10 standards, and these standards are the same for AADE or ADA recognition. And let me just back up a little bit, and I think everybody probably is already aware of why it's important to have either AADE or ADA recognition. But one of the main reasons is for insurance reimbursement. And when we're running programs, whether it's an individual program outside of a hospital or within a hospital system, knowing that you have some kind of reimbursement and will help maintain our services, maintain them to be sustainable, and that's something that I know that we're all working on maintaining sustainability for our services. So there are the 10 standards. We have internal structure. It's stakeholder input, which is another really important piece of maintaining and developing a program. We want to know who our stakeholders are and what's important to them, and aligning with the needs of the community, because as we all know, Wyoming is a big place, and each community has its own little nuances and things that are important to that community. So this is a really great way to make sure that our services are reflecting the needs of the community. And there again, that's something that I really value in this program and for these programs. Evaluation of population served is the third standard. So just really just really getting to know your population. Who are they? What do they need? And of course, we have these wonderful, I'm going to totally blank on the name, needs assessment the needs assessment reports are really informative, and they can really help us evaluate the population that we're serving. The quality coordinator overseeing DSMES services, and that's the person that's going to be responsible for all of these different pieces, for gathering the information and really knowing the community as well. The fifth standard is the DSMES team. I like that there's a team of people. This is not a solo undertaking, or, it could be a solo undertaking, but, that would be quite challenging for sure. Curriculum, everything is individualized. So individualization is the seventh standard. Ongoing support, again, I think that the way that these programs that are the services are going is to really make sure that they're sustainable, creating a sustainable program. Standard number 9 is participant progress, and 10 is quality improvement. One of the main changes that came about with the 2017 standards was the change in the curriculum. So it's the curriculum is now determined by the need of the individual participant, and that will determine which elements of the curriculum are required. So we used to go through, all of the different standards, and now we're really going to be doing an assessment of the participant and making sure that we cover what's important for that participant, as opposed to just going through a checklist. So really working toward that individualized care for that patient, participant. And of course, I'm going to keep going back and forth between patient, client, and participant, because I work in so many different roles, but it's participant. Participant is the correct terminology. So excuse me if I keep going back and forth. I'm going to try to work on that for 2018. So there are core content areas. The AADE 7 healthcare behaviors are some of those core content areas, and they have demonstrated successful outcomes, and they must be reviewed to determine which are applicable to the participant. And so that's when a really great assessment comes in handy. The core content areas. These are the core content areas. So diabetes and pathophysiology and treatment options, healthy eating, physical activity, medication usage, monitoring and using patient-generated health data, preventing, detecting, and treating acute and chronic complications, healthy coping with psychosocial issues and concerns. And there again, that's a place where you may need to bring in an expert from outside of your program, maybe having that referral source to mental health, or whatever works in your community. And also problem solving. The other piece of the core content areas that I think is another really important piece is educating the participant on navigating the healthcare system. So that we could probably spend a whole hour on talking about that, how to navigate the healthcare system. And basically what that's going to lead to is learning self-advocacy, and also e-health. So there's navigating the healthcare system, I think, can be challenging for some and easy for others, and just recognizing that some people are going to be really great with technology, and others are going to maybe struggle a little bit more. So that's when that individualization really comes into play, I think. So it's crucial that the content be tailored to match the individual needs and must be adapted as necessary for age, developmental stage, types of diabetes, of course, cultural factors, health literacy, and numeracy, and other comorbidities. So I'm going to switch to talking about the benefits of a DSMES program. So again, quality of life. I think that's what we're all in this for, is to really help our participants achieve a higher quality of life. Healthy eating, physical activity, self-efficacy, empowerment, healthy coping. If people do have complications, helping them figure out how they can be coping with those complications. And of course, improved hemoglobin A1C. I did read something this morning about physical activity and how it seems to be that the trend right now is going to the gym and all of those things are wonderful, but really I think the push that we've seen in the last maybe year is to really just be more active. So, I've seen everything, tips as far as getting up every hour if you're sitting at a desk. So really just reducing the amount of sitting time in one's day. And as we all know, living in Wyoming in the winter, that can be challenging. So that's where we come into play as educators and helping people find ways to be more active during the winter, whether it's going to the rec center or making sure, something that I always do is I always ask my patients, I always look at their footwear. That's something that I've always done. If they come walking in my clinic and they're wearing Crocs and it's February, number one, that's a signal to me to have them take off their shoes and make sure that their feet are don't need to be evaluated more. But also, wearing and this may be something that other people have seen as well. People wearing shoes like Crocs in the wintertime, that can be really dangerous. So really talking to people about, proper footwear and evaluating their feet and all of those good things. So that's physical activity. So the other benefits are we want to reduce hospital readmissions, reduce some of those healthcare costs. Remember that those numbers from the beginning of the slides, Wyoming alone, inpatient visits over $232 million, over $232 million per year. That's an incredible cost. And again, behind that cost is there's always a patient suffering with some kind of complications behind that. Reducing diabetes complications, reducing diabetes-related distress, and depression. And there again, we know that people with diabetes have almost twice the risk of developing depression. So really, as I go through this, as I'm going through this talk, I'm thinking about all of the things that we as diabetes educators, or even if you're not a diabetes educator, if you're working with a clinic, we're really in charge of, thinking about the whole person in a way where we're helping, empowering them, finding ways for them to, helping to working with them to find ways to be healthier. But it's holding a lot, I guess is what I'm trying to say. We're holding a lot of information when we're working with those participants and really tuning into their individual needs. And I think that that's really, and I guess I feel like it's a very honorable role that we play in the lives of our patients that are living with chronic disease. Okay, so this is an algorithm of care. I love these algorithms because they can be really helpful for us as educators, and they can be really helpful to share with our healthcare providers as well, whether it's our doctors, our nurse practitioners, our PAs, or whoever we're working with. And let's see. So this algorithm starts with the ADA standards in medical care, recommends that all patients be assessed and referred for nutrition, diabetes self-management education and support, and of course, emotional health. And so you can just see that through here. So critical times to assess, provide, and adjust diabetes self-management education is separated into four different areas. So at diagnosis, an annual assessment, and that annual assessment includes education, nutrition, and emotional needs. And the third piece of this algorithm is when new complicating factors influence self-management as well. And so there again, that's when, working as a team really comes into play, and knowing just having that open communication with other providers, and when transitions in care occur as well. So that algorithm really gives us an idea of when we need to be intervening with our participants. See, I told you I was going to keep going back and forth between clients and participants. And you can see there's action steps associated with all of these 4 areas. So the 4 critical times to assess, provide, and adjust diabetes self-management, education, and support. So at diagnosis, annually, when new complicating factors arise, and transitions in care. oops, sorry, I have a typo there. It should be DSMES reimbursement. To be eligible for reimbursement, we must meet the 10 national standards that we went through in the beginning of the program. And just another note that the Stanford license programs are wonderful programs, but they are not eligible for insurance reimbursement. So with Medicare, we must obtain a referral from a healthcare professional and receive, and the training must be received from an ADA or an AADE accredited program. We're allowed up to 10 hours of individual care per year, and up to 2 hours of training each year after the initial 12 months. So if anybody has questions on that, please let me or Diane know. Diane's really good at doing maximizing the number of hours that we're allotted for insurance reimbursement. So for Medicaid, must obtain a referral from a healthcare professional and receive training from a CDE or a dietitian, up to 1 hour of individual training, additional DSME in a group setting. Let me see if there's anything new in this. So for reimbursement, if it's a private payer, must obtain a prescription from a healthcare professional and receive training with someone with expertise in diabetes. They must have a one-time evaluation and training program within 1 year of diagnosis. There is an additional training is up to about 3 hours per year, provided upon significant changes in symptoms, conditions, or treatment. And it's subject to some annual deductibles or co-insurance for all other covered benefits. And this is from the Wyoming statute, whatever that stands for, sorry. So these are the current DSMES programs in Wyoming. And you can see that the blue ones are ADA recognized programs, and the yellow ones are AADE accredited programs. And I'm happy to report that there is a new AADE accredited program on the Wind River Reservation. And that's at the Northern Arapaho, and Susan Krieger and Donna Estep are the facilitators of that program. But you can see that there's still a lot of room for other programs throughout the state. We're certainly not saturated, I don't think. And one of the things I also wanted to say about this too is that there's also, you can partner with people if creating a program from the ground up seems overwhelming. In, say, you lived somewhere nearby a program, you could actually partner with someone to develop a program. And I think that that's a really great option as far as, getting a program up and going in your community. There are also DSMES programs via the web. And that's becoming a really, obviously we're doing this talk today web-based, so this is really becoming a really wonderful adjunct, I feel like, in Wyoming, especially when we have winter and, difficult roads, and people in general, may live far distances from sites. So, programs via the web are certainly an option. Here are some information about becoming a recognized program. So from the American Diabetes Association, the American Association of Diabetes educator, and from Stanford Medicine if you are interested in the Stanford programs as well. I'm just going to read this. So in order to enhance patient and family engagement in DSMES, provider communication about the necessity to self-management to achieve treatment and quality of life goals, and the essential nature of both DSMES and ongoing support throughout a lifetime of diabetes is essential. I couldn't agree more. And that's why we're here to help if anybody is interested in developing a program. So now I'm going to change and talk about the diabetes prevention program. And we've been holding monthly webinars about the diabetes prevention program, and those are recorded. But again, if you have any questions about creating a program, Diane or I can certainly help with that as well. So now we're going to, the DSMES program is really talking about having known diabetes. The DPP program is is for preventing developing diabetes. So prediabetes is a reversible cardiometabolic risk factor in and of itself. So having prediabetes is a reversible risk factor. So it's diagnosed when between 110 and 120, a fasting plasma glucose between 100 and 125, an A1C between 5.7 and 6.4 with no prior diabetes diagnosis. Risk factors for diabetes include being overweight or obesity, lack of physical activity, age, so your risk increases with age. Certain races and ethnicities are at a higher risk factor for developing prediabetes, and low birth weight. And this is all from the Centers for Disease Control and Prevention. So again, 5.7 to 6.4 is the A1C the A1C for diagnosing prediabetes, or a fasting plasma glucose of 100 to 125, or an oral glucose tolerance test between 140 and 199. And you can see what the normal ranges are as well. So a normal A1C is about 5, and a fasting plasma glucose is 99 or below, and an oral glucose tolerance test of 139 or below. So the NDPP program is a year-long program, and it's a lifestyle change program that's following an evidence-based CDC-approved curriculum. It's designed for people who have prediabetes or at risk for developing type 2 diabetes. It consists of 16 weeks of an intervention followed by 6 months of maintenance and follow-up. So this is a year-long program, which I personally think is brilliant, because we're really, this type of program is really going to support the participant. Sorry, see, I keep doing that. The participant from the beginning throughout a whole year-long process. And this is the curriculum. So you can see that the first 6 months, and the way that this works is the first 6 months people, there's a couple of different ways to structure it, but for the first 6 months, people meet about once a week. And there's, each session, they'll follow the curriculum, but, get active to prevent type 2, track your activity, getting more active, managing stress, shopping and cooking to prevent type 2 diabetes. That doesn't include the holiday cookies. Coping with triggers, keeping your heart healthy, taking charge of your thoughts, getting support. So you can really see, if you look at the curriculum, that it's really an all-encompassing program. So it's not only about food and activity, it's talking about triggers, getting support, and really finding and really encouraging participants to develop healthy, sustainable lifestyles, basically. And then the last 6 months of the programs are when weight loss stalls, taking a fitness break. That always makes me go a little sideways, taking a fitness break, staying active to prevent type 2, staying active away from home, more about type 2, more about carbs, have healthy food you enjoy, getting enough sleep. For those of us working with participants, I know that for myself, that's something that comes up with almost, I would say, a high percentage of patients. We talk about sleep, getting back on track. I always think about that, the stages of change, and I like the stages of change model that occurs in a spiral, because sometimes we'll go up and sometimes we'll slip back, but we can always go back up. And preventing type 2 diabetes for life. So the NDPP is basically a result from a major clinical research study that I think began in 1998. And in that original study, there were 3 arms, and it was a randomized controlled trial. So we had a control group, an intervention group, which received metformin, and we had an intervention group, which had intensive lifestyle coaching. And the beauty of this is that the intervention group 2, and these are the things that they basically reduced their risk of developing diabetes by 58%. And the variables that helped achieve that were a 5 to 7% body weight loss. And that's an achievable number for most people, and that's one thing that I feel like as a clinician is really exciting to share with our patients, that we're not recommending that people achieve their freshman and high school body weight. We're recommending a 5 to 7% weight loss, and that's an evidence-based goal. There was also an outcome 10 years after the study, and that demonstrated a 34% decrease in the prevalence of type 2 diabetes. So for those of us that like numbers and research, that's amazing. So that's really, really exciting, and that's one of the main reasons that we've been supporting this program and really trying to get people to adopt a national diabetes prevention program. So there again, this is really just a summary of what I was saying. So the intensive lifestyle intervention group reduced their risk of developing type 2 diabetes by 58%. Whoa, that's awesome. And, oops, I think that, sorry, I told you I was having see if I can, and I think that's all I have. I must have missed a slide in there somewhere, so I apologize. But that's basically the a very brief overview of the National Diabetes Prevention Program, and I'm certainly available to answer questions about the prevention program or the DSME-S program as well.
Super. Well, thanks, Maureen. I want to give everyone a chance to go ahead and submit any questions you have in the chat feature. We'd love to have those. We've got some time. Maureen, and I know Diane, you're on the phone, but when would you like to talk about your upcoming lifestyle coach training you have happening in March?
Oh, it is.
Available?
I am. We've scheduled a 4th session. It's
I think she's trying to talk through the computer.
Okay.
Diane,
hold on. Let me unplug. Hold on.
You'll have to do it, Maureen, if you want.
Okay.
Yeah, is that better?
Here is an upcoming coach training. So in order to facilitate the National Diabetes Prevention Program, one has to be a trained lifestyle coach. So Diane has done an amazing job in Wyoming in organizing training programs here. Otherwise, people would have had to go out of the state, and it was quite expensive to go to some of the other programs. That's not to say that there's nothing wrong with going to the other trainings, but we wanted to make it, keep it a little bit more local and more affordable, because budgets are budgets. And so I don't have those.
I have it. I had to look it up. So
I think it's
I had to
the
unplug.
14th and 15th of March.
Yeah.
Um,
I'm unmuted.
but as soon as Diane calls in,
Oh, I'm here. I should be here, Maureen.
well, and that's going to be in Casper. And the training, I took the training this past October in Douglas, and I really enjoyed it. It was a great training, and I think even just as much as I enjoyed the training, I enjoyed getting to know some people from around the state that were also interested in developing diabetes prevention programs. And so that was really an extra bonus for me, was being able to interact with so many people from around the state. Do we? I'm not sure I'm able to get the chat box, but I think there was
I
some.
don't know if she's going to get on. I was able to pull up that flyer, and it's scheduled. You guys have it scheduled for March 15th and 16th.
Okay.
And it's in Casper, and it's going to be at the Hampton Inn Conference Room. Registration is very reasonable, and what I can do is I'm happy to send out this flyer to everybody who joined today, just as an additional resource.
Great. And you can email Diane at diane.true@gmail.com if you want more information.
Oh, okay. Great. Excellent. So any questions from our folks that have joined us today? Got a couple of wonderful experts on the phone, ready to help.
So that was a lot of, I gave you a lot of technical information about the programs, and I just want to say that from running a program to creating programs, I feel like having a recognized program, whether it's AADE or ADA, it doesn't matter. Whatever works for your needs really helps to bring some recognition to your community about diabetes, and it helps, I think, foster connection with our physicians as well. And so that's just my experience, but I thought I'd share that.
Great. Well, Maureen, I appreciate your time today and everyone who's joined us. I won't keep you on the phone just because we've got a little time left. Enjoy the rest of your day and the upcoming New Year's. And thanks again for participating in this final diabetes series. And Maureen, again, thank you very, very much.
Thanks, everybody. Reach out if you have any questions at all.
Thank you.
Leave meeting. We love leave meeting.